Dear colleagues, I'm Christoph Diener from the Medical Faculty of the University of Duisburg-Essen in Germany. And this video deals with the treatment of stroke. I would like to start with primary prevention. We all know that DOACs, direct oral anticoagulants for stroke prevention and atrial fibrillation, is as effective as vitamin K antagonists, but they have fewer bleeding complications. But they still have bleeding complications, and the most frequent ones are gastrointestinal bleeds. Abelacimab is a monoclonal antibody targeted against coagulation factor 11. And the hypothesis is that this drug should be as effective as a DOAC and lead to fewer bleeding complications. And this was investigated in a phase 2 trial in 1,267 patients with atrial fibrillation. And the monoclonal antibody was compared to rivaroxaban. Abelacimab had significantly fewer serious and clinically relevant non-serious bleeds, a reduction by 60% after 20 months compared to rivaroxaban, but there was also a higher risk of ischemic events. This study was published in the New England Journal of Medicine, and this requires now a large phase 3 trial where ischemic events, in particular ischemic strokes, are the primary endpoints. Now let me move to the International Stroke Conference, which happened in February 5 to 7, 2025 in Los Angeles. You are all aware that systemic thrombolysis with either alteplase or tenecteplase in a 4.5-hour time window is highly effective. But currently we have further studies on the use of these two drugs in the time window between 4.5 and 24 hours using perfusion imaging to identify penumbra. HOPE was a study with 370 patients and compared alteplase with best medical treatment in a time window between 4.5 and 24 hours and found a therapeutic benefit for modified ranking 0 to 1 after 90 days, but with a higher rate of symptomatic intracerebral hemorrhage of 3.8% for alteplase compared to 0.5% for control. Previously, a study in China, the Chablis trial published in Stroke, with 224 patients compared tenecteplase to best possible treatment in the same study design time window 4.5 to 24 hours, and there was no benefit for functional outcome and an increased bleeding risk. So this means for this research question, we still need more studies. We have now many studies which compare tenecteplase and alteplase in the 4.5-hour time window in acute ischemic stroke. And a recent meta-analysis in neurology of 11 studies and 7,500 patients found a minimal benefit of tenecteplase over alteplase with comparable mortality and symptomatic intragranular hemorrhage. The only advantage of tenecteplase is that it is given as a bolus, but it's also more expensive than alteplase. And we also know that endovascular therapy is highly effective for occlusion of proximal brain-supplying arteries, in particular in the arterial circulation. At the conference, there were 3 new studies presented on the potential benefit of endovascular therapy for occlusions of middle or distal arteries in the arterial circulation. The distal study with 543 patients, the ESCAPE trial with 529 patients, and DISCOUNT with 152 patients. All 3 studies found no benefit of thrombectomy in this population compared to standard therapy, but showed an increased rate of bleeding. Thrombectomy remains highly effective in proximal occlusions of brain-supplying arteries. We also know that endovascular therapy has benefits for occlusions of the vertebral and basilar arteries. This has been clearly demonstrated. A recent meta-analysis in Lancet comprised 4 studies on endovascular therapy with 556 patients with occlusions of the vertebral or basilar artery and compared thrombectomy with best medical treatment in 432 patients. And this showed a clear superiority for modified ranking equal or less than 3, with 55% for thrombectomy versus 30% with best medical treatment. There was an increased bleeding risk, but still reduced mortality regardless for thrombectomy. The greatest benefit was for proximal occlusions and in a time window of less than 12 hours. There is now a new approach, interestingly, for intra-arterial thrombolysis after successful endovascular therapy. There was already one positive study in Spain, and at the ISC, the ANGEL TNK study was presented, and this study randomized 255 patients and found a significant reduction in functional outcome modified ranking 0 to 1 or better outcome after 90 days, with 40.5% for intra-arterial thrombolysis versus best medical treatment with 26.4%. Mortality and symptomatic intraarterial hemorrhage were not different. And there is also an important clinical question whether anticoagulation with DOACs can be resumed after intracerebral hemorrhage in patients with atrial fibrillation. The Prestige AF study, which was presented at the conference, randomized 150 ICH patients to DOACs and 161 without DOACs. And for ischemic strokes, there was a large difference in favor of the DOACs with 0.8% versus 8.6%, but there was also a significant increase in recurrent intracerebral hemorrhage with 5% for DOACs versus 0.8% for no DOACs. And therefore, we cannot really estimate what is the real benefit compared to the risk in this population. But we have still 3 studies ongoing, which possibly will answer this important research question. So, dear colleagues, interesting new studies, most of them presented at the International Stroke Conference in Los Angeles. I'm Christoph Diener from the Medical Faculty of the University Duisburg-Essen in Germany. Thank you very much for listening and watching.